afternoon, everybody. I'd like to welcome you all to today's webinar. It's already 2 o'clock, but we'll have to wait for a couple of minutes to allow some other people to join us. Already our guest speaker is around, Dr. Chinyere Iwuji, and we'll just give a couple of minutes for people to join us before we start. My name is Dr. Ademola Adeyeye. Thank you for the patience in attending this meeting. Like I said before, I'm standing in for our regular host, Dr. Mrs. Yemisi Adeyeye, who's working in the background to make sure that this meeting takes place and it's running smoothly. So I also like to welcome everybody. We have about 53 participants so far in attendance, and especially to welcome our guest speaker, Dr. Chinyere Iwuji, who will be speaking shortly. So the title of today's webinar is the conduct of chemotherapy and palliative care for cancer patients in the era of COVID-19. However, we have decided to split into 2 topics so that we'll be able to have a more condensed presentation and better understanding of the issue at hand. So before we go ahead, I would like to talk about my role in this presentation. So I'm supposed to welcome us all to this webinar, which I have done. And I want to paint a background and a preamble and before introducing the guest speaker. So we know that cancer is the leading cause of death worldwide. And we know that in 2012, across the world, we had more people dying of cancer from HIV, AIDS, tuberculosis, and malaria all combined. Although in Africa, we still have more patients dying from HIV, AIDS than those other conditions, but cancer still beats all the deaths from tuberculosis and malaria, and is a great source of concern. And we know that the cancer burden in less developed countries like Nigeria is increasing and will be much more than the developed world by 2030, and that there's a big gap even in the mortality rates for this condition. We know that in low-resource countries like Nigeria, we have problems with manpower, with materials, with machines, the mechanisms and policies, as well as money. And of course, we do not have the time to take care of all these patients because there are other conflicting interests. We know that cancer in this part of the world tends to occur in patients who are younger than the average Western population. They tend to be more aggressive. They tend to come in more advanced stage, and many of them are stage 3 and stage 4 cancers. And usually for stage 3 and stage 4 cancers, chemotherapy with or without palliative care is the mainstay of treatment, hence the need for this discussion today. We know that the COVID-19 era has brought new challenges into the foreplay, and that is why we need to have a better understanding on how to relate our patient management with the new realities we find ourselves in. We know that WHO has ranked or has identified the resource management among different countries in terms of cancer care, and the latest profile for 2020 doesn't give a good picture for Nigeria. Now, Nigeria with a population of over 200 million, the largest population in Africa, recorded in 2018 over 100,000 new cancer cases, which we feel is a gross underestimation because not everything is being reported. And we had more than 70,000 deaths, which we feel again is still a gross underrepresentation. Most of our cancers are breast cancers, cervical cancers, prostate cancer, and colorectal cancer, as well as liver cancers. Unfortunately, there is no public center in Nigeria that is devoted to cancer care. We do not have any early detection program for breast, cervical, colon, or childhood cancers. Even though pathology services are generally available, for palliative care, it is generally not available either in the community or on home-based scenarios. And there was a time between 2015 and 2017 where the opioids were not available to manage our cancer patients. Right now, things are a little bit better, but it's still patchy or sporadic at best. And that is why it's a major source of concern for us, because opioid for pain control is a major aspect of palliative care. Well, there's an operational national cancer control program in place, but its implementation is another problem entirely. There are no guidelines for managing cancer patients in the country. And there is no palliative care included in the operational plan for 2019. We don't have effective plan for treatment for surgery, chemotherapy, and radiotherapy for our patients. And there's no definite screening program for cancers, especially breast cancer, in our environment. But again, chemotherapy is available, but only a fraction of our patients who require chemotherapy actually even get it. And that's another major cause of concern. Now, a quick word on surgical palliation. Even though this is going to be a mainly medical presentation, but surgery has a brief role in palliation. And because most of our patients come in with advanced disease, we can get to do this a lot. So resections. Can be a mainstay of palliation. And then we can also do non-resectional surgery, such as diversions, drainage, decompression, debulking, and dietary measures. So in our own scenario and our setting, we tend to see a lot of patients with advanced disease who need intestinal stomas, like in the picture that we've shown in here, as well as patients who need drainage for abscesses from perforations or decompression of gastric obstructions, debulking, especially in O&G, and feeding jejunal for dietary measures. I'll see my screen. So I was trying to say that on a quick one on palliation, that we can do resectional surgeries and non-resectional surgeries. And I've already mentioned the non-resectional surgeries, the 5 Ds. So just to save time, because we are almost eating into the guest speaker's time. So Dr. Chinye Iwuji is a medical oncologist and consultant with the National Hospitals of Leicester in the UK. And she qualified as a medical doctor in 2003 in the University of Southampton. She did her oncology training in Leicester and has a master's from the University of Nottingham. She also has a PhD, and her interest in that PhD was in treatment of colorectal cancer patients. Now, so she's a rising star in the medical oncology world in the UK and has special interest in hepatobiliary colorectal cancers as well as neuroendocrine tumors. She also has a knack for medical education and tends to take undergraduate medical students at the University of Leicester. She has also, as a Nigerian in the diaspora, given back to the community, and she comes regularly to Nigeria to see our medical students and other doctors in training, to encourage them and to give them a encouragement on how to go about their training. I met Dr. Uji in Leicester, and I've had the opportunity of sitting with her in her clinic, and also hearing her speaking on different platforms. And I can say that she's a very erudite scholar who has a lot of experience to share with us. So without further ado, I would like to invite Dr. Iwuji to start her presentation while I start sharing and allow her to share her screen.
Okay, great. So thank you very much. Good afternoon. It is my pleasure to be here this afternoon to speak to you about both chemotherapy and palliative care in the treatment of cancer patients during this era of COVID-19. Thank you, Dr. Adeye, for the introduction. So I will just move ahead with the topic. So I'm going to start off talking just about chemotherapy to begin with, and then the second presentation will be about palliative care. So just to give you a little bit of background, I am based in Leicester, which is right in the middle of the United Kingdom. I'm going to focus my talk speaking about how we were able to manage cancer patients in chemotherapy, specifically in Leicester. And that is because what we have found is that the treatment of cancer patients throughout the UK has varied significantly just from center to center. So the way we treated cancer patients in Leicester was very different from how cancer patients were treated, for example, in Birmingham, which is literally just an hour away from us. In terms of how the COVID-19 epidemic affected us in Leicester, to be honest, initially when COVID-19 hit, we were not that dramatically affected in Leicester. Our numbers did not go up as high or as we had feared. We were not overrun with patients as we had anticipated. But what we found was that as the United Kingdom was easing out of the lockdown, actually Leicester was the first part of the whole country whereby we were told that we had to stop easing out of lockdown. We actually in Leicester were told that we had to go back into lockdown, even though the rest of the country was coming out of lockdown. And so we have been easing out of lockdown in Leicester a lot more slowly than the rest of the country. So what I'm going to speak about today is COVID-19. I'll just give you a bit of background about how COVID-19 presented in the United Kingdom, and then the impact it had on us in terms of managing chemotherapy, how we were actually able to practically administer the chemotherapy, and just a slight, I guess, introduction into how this might have affected or will affect patient outcomes in the future. So in terms of COVID-19 in the UK specifically, as I'm sure you all know, the UK was hit quite badly with COVID-19 overall. We had the second highest rate of deaths due to coronavirus or COVID-19, and the most recent data over the last few weeks has shown that we had about 46,000 deaths in the United Kingdom. So this is a high rate overall, the second highest rate overall, and the second highest rate per capita in terms of comparing the UK, for example, to the US or to Belgium. In terms of how COVID-19 developed in the UK, it really started becoming evident that COVID-19 was hitting the UK at the end of February, beginning of March. And then we hit our peak of COVID-19 cases between March and April. And then as we started heading into May, the COVID-19 case numbers started dropping. And by around this time, June, July, August time, we have plateaued slightly. We are concerned that the numbers might start going up a bit more in August. And we are also worried about what will happen when winter comes, because we know that in the winter, we tend to have flu epidemics anyway. And this is when our patient numbers increase and our patient mortality increases. So with the addition of COVID-19 in that setting, it is a source of concern. In terms of lockdown in the UK, when our numbers started going up at the end of February to the beginning of March, the UK officially started its lockdown on March the 16th. And then when the COVID-19 cases started coming down, we started easing out of lockdown and around June 23rd. So when we were thinking about how to manage chemotherapy, even though we did not go into lockdown until the 16th of March, we as an oncology department really started instigating our chemotherapy management plan right at the beginning of March, I would say around March the 1st or the 2nd. And that is because we had a close eye on what was happening in Italy. When COVID-19 hit in the UK, we were very aware of the fact that there was only a 2-week lag between what was happening in Italy and what was happening in the UK. And as you can see from this graph where the COVID-19 epidemic in Italy is shown in red versus the COVID-19 in the UK being shown in blue, we were almost matching them point for point, but just lagging 2 weeks behind. And it was all very concerning because this, as you see the statement from one of the doctors in Italy, what he said was, there are no more surgeons, urologists, orthopedists. We're only doctors who suddenly become part of a single team to face this tsunami that has overwhelmed us. And that is what we were concerned about, that we had an oncoming tsunami about to hit the NHS. Now, in fairness to our department in Leicester and in most of the country actually, what we found was that the oncology department was protected in comparison to a lot of our colleagues in other departments. What was happening in hospitals throughout the country and certainly in Leicester was that other departments were being shut down so that their doctors could be deployed to the COVID-19 front line. But the policy that we had in our department was that the oncology doctors would be held at bay, as in we would be kept in our oncology department and we would try to maintain cancer services for as long as possible and only be deployed to the COVID-19 departments and wards as a last resort. So we were able to just continue managing our cancer patients and we were protected from the COVID-19 pandemic. But what we started doing right at the beginning of March was to anticipate how would we be able to ensure that we did not expose our cancer patients unnecessarily to the risk of COVID. How would we make sure that we as a department would not become overwhelmed? Because if we continued treating our cancer patients at the same rate as we had been treating them before, and yet we would be facing shortages of staff who are affected by COVID-19 and also be having a high number of patients being admitted with COVID-19, this would be something that we as a department were not able to handle. So what we decided to do was to significantly streamline the number of patients who are receiving cancer treatment from our department. So in order to do this, first of all, we started by trying to figure out who were the most vulnerable cancer patients. But to be honest, that turned out to be pretty much all cancer patients. So any patients being treated with any form of treatment, so chemotherapy, radiotherapy, immunotherapy, and targeted treatments, that would reduce their immune system, so they would be at risk. We all know that cancer in itself also reduces the immune system. So just by definition, before we even give our patients any form of treatment, they would be vulnerable and at risk. Patients who have Any cancers of the blood or bone marrow would also be at high risk, regardless of what stage they were on in their treatment. So leukemias, lymphomas, myelomas, they would all be at risk. Patients who have had any form of bone marrow or stem cell transplant in the last 6 months, or who are still taking immunosuppressive drugs would also be at risk. And then in addition to this, it was compounded by any patients who had significant comorbidities or who were at higher risk based on the studies that we already knew from COVID-19. So this included any patients who were over the age of 60, any patients who had pre-existing cardiovascular or pre-existing respiratory diseases. All of these factors put these patients, and particularly our cancer patients, at a higher risk. So in order to decide which chemotherapy agents to continue giving our patients, we decided to come up with a traffic light system that would prioritize which were the most significant treatments that our patients would benefit from, so that would get the most benefit and offer them the least risk. So like I said, pretty much all of our patients would end up being high risk, but which of their treatments were beneficial enough to put them at that risk? So we started off with priority level 1 and 2 patients. These are patients who were having treatments that had a high percentage, a high chance of being curative. So if you're being given a curative chemotherapy that had a 15 to 50% chance of success, then these were priority levels 1 and 2. So they were green light patients. These are the patients that we wanted to continue treatment on for as long as possible. Priority level 3 patients were in the amber category, so they might be having non-curative treatment, but it still had a high chance of prolonging their life by over a year. Whereas priority level 4 patients were still in the amber zone, but these are patients who might be having curative treatment, but the chances of success were lower, or they might be having non-curative treatment, but it still had a significant chance of prolonging their life by over a year. By the time we got to priority 5 or 6 level chemotherapy, this is chemotherapy that would have a low chance of any curative success, and we thought that its chances of improving survival by a year would be low. So these are patients who are having palliative treatment that would not likely survive up to a year. And in these cases, we considered palliative chemotherapy as almost a luxury, and these are the patients who are most likely to stop treatment on. So that equated to this traffic light system. We were able to look at the different kinds of cancers that patients had, look at the different chemotherapy options that we were giving them, whether they were neoadjuvant, adjuvant, first line for advanced metastatic disease, second line or third line. And then we would then look at the chemotherapy options we had and decide based on the potential benefits of that chemotherapy, whether they fitted into red, amber, or green. So as Dr. Adeyeye said at the beginning, I specialize in colorectal cancers, pancreatic cancers, basically hepatobiliary cancers, and neuroendocrine tumors. So that puts me in this category here. The majority of my patients will present at an advanced stage of their disease. So they would present at a stage where they had metastatic disease, they might be on second line or third line chemotherapy. And as a department, we decided within the first 1 to 2 weeks that we would stop all category 5 and 6, priority level 5 and 6 treatments. And then by the time we got into the second to third week of COVID-19, we actually also significantly reduced our priority 4 chemotherapy treatments as well. So you can see that this pretty much wiped out my practice within just a couple of weeks. The majority of my patients would fit into the categories of patients who were not getting enough benefit from the chemotherapy to put them at risk of coming into hospital for this treatment. I was only able to continue treatment for patients who are having neoadjuvant or adjuvant treatment for their cancers. And even then, for a lot of my patients, for example, with the colorectal patients, even if they were having neoadjuvant or adjuvant treatment, if they were over the age of, like I said, 60, if they had significant comorbidities of cardiovascular or respiratory disease, we would also avoid giving them chemotherapy. So this was a big problem in my practice. For other cancers, however, breast cancer, you can see that there's still a large proportion of patients who are having chemotherapy that would put them in priority level 2 to 3, and therefore they were able to continue giving their patients treatment. In terms of lung cancer, it was very dependent on whether they had small cell lung cancer or non-small cell lung cancer in terms of what treatment they were able to have. And with a lot of the hematological malignancies, because they have such good outcomes, they were able to actually continue their treatment over a prolonged period of time. So they had a lot of patients with priority 1 to 3 level chemotherapy, and therefore they could continue treating these patients. There were other considerations that we had to look into as well in terms of how best to administer our treatment, but also reduce exposing our patients to the COVID-19 risk by bringing them into hospital. So for example, if we had patients who would normally be having intravenous treatments, we would try and change them to either subcutaneous or oral chemotherapies. So for example, my patients who had colorectal cancers who would normally be treated with 5-FU IV infusions, we tried to change them to oral capecitabine instead of IV 5-FU wherever possible. We tried to space out our treatments as much as possible as well. So if they would normally be having 2 to 3 weekly treatments, we would change them to 4 to 6 weekly regimens instead. We would dispense longer periods of oral medication. So normally with capecitabine, we would normally dispense 4 weeks worth of treatments on the understanding that in 4 weeks time, the patient would come back into hospital, have blood tests, be seen in clinic, make sure they're okay before we give them the next 4 weeks. But with COVID-19, we ended up giving patients a 3-month supply of treatment, of medication, and then we would just call them remotely every month and tell them whether to go ahead with taking that treatment or not. We do offer our patients, particularly patients, for example, with bone metastases, supportive therapies in terms of denosumab and zoledronic acid. And the aim of these treatments is to reduce the risk of complications of bone metastases, so to reduce the risk of fracture and to slow down the rate of advance of those bone metastases. But we had to stop these supportive therapies during COVID-19. Where possible, we tried to deliver any oral medication or subcutaneous injections to the homes of the patients. And we actually found that the pharmaceutical companies were very helpful with this, understandably, because they would be going out of business if we stopped using their medication. So they were very helpful in providing home delivery of their medications to the patients. And actually, some of the pharmaceutical companies have actually provided phlebotomy services. So they would go to the homes of the patients to offer blood tests as well, so that the patients would not have to go into their GPs or come into hospital to have the blood test done. For some of our patients, we just stopped their treatments and gave them a treatment break during the height of the coronavirus. And in terms of the actual clinic appointments, like I said, we swapped over to telephoning patients or doing virtual clinics, video conferencing or video linking to the patients where possible. We did consider the use of GCSF or filgrastim, which is often given to patients to boost their immune system, to boost their neutrophil count. We did consider that as a form of primary prophylaxis during the COVID-19 epidemic, but we decided that actually the evidence for this was very limited, the cost for it would be very high, and there just wasn't enough of a benefit for us to be offering this to all of our patients. So we did not give GCSF prophylaxis to any of our patients, even though the government recommendations suggested that it might be helpful in some cases. So how did our patients react to all of this? Because as you can imagine, when I say we stopped giving priority 4, 5, and 6 chemotherapy to patients, it wasn't just patients who were newly diagnosed. So that would be bad enough. You have a patient who's newly diagnosed with a cancer. Of course, everyone is terrified of having a cancer. They want treatment. In the UK, with our NHS system, there is an entitlement to having that treatment. So it's not a case of them having to find money to pay for the treatment. It's a given that patients will receive that treatment provided that they're part of the NHS. And suddenly we were telling our cancer patients that even though we know you have a cancer that you might die from, we are not going to give you any treatment. And in addition to that, we had some patients who were halfway through their treatment or in the middle of their treatment and had just started their treatment. And we were having to tell them that actually we're going to stop this treatment in the middle of a COVID-19 epidemic. We're just going to stop your chemotherapy then and there. So how did we deal with this? Really, it came to good communication and having to explain to the patients what exactly we were doing and why we were doing it. So I always approached it this way. I would start off by telling them the scariest part of the situation. I would tell them that because of their cancer and because of their chemotherapy, they were very high risk for contracting COVID-19 because both the cancer and the chemotherapy reduced their immune system and would make them more susceptible to getting COVID-19. Secondly, I would explain to them, if it was appropriate, that if they were older and if they had significant comorbidities, this also would increase their chances of getting COVID-19 and would mean that their prognosis in terms of surviving a COVID-19 infection would be a lot worse, this is all factual. I was just being honest with them. And then I would add to the information, the fact that if you already have a low immune system, if you're already at risk of catching COVID-19, then the last place you want to come to is the hospital, because that is where all the COVID-19 patients are. So your chances of coming into contact and catching COVID-19 will be highest every time you come into hospital. And then I would explain to them again that if they did catch COVID-19, we really at that time did not know how cancer patients would react. The prediction was that cancer patients on chemotherapy would do very badly. And that we also explained that if they did get COVID-19, we didn't know what kind of capacity we had to deal with it. We didn't know what kind of capacity we would have to deal with normal chemotherapy side effects like neutropenic sepsis, nausea, vomiting, diarrhea, constipation. These are things that before COVID-19, it was taken for granted that our patients would be able to come into hospital and be treated for these complications. But with COVID-19, if our wards were overrun with COVID-19 patients, then we might not be able to offer them that supportive service. To be honest, for the vast majority of patients, by the time I explained all of this to them, they were more than happy to stop their chemotherapy. For some patients, before I even started explaining this to them, they were happy to stop their chemotherapy. I had one lady who was actually a very good candidate to have adjuvant chemotherapy. We were more than happy to give her adjuvant chemotherapy, but with all the reports that patients had been hearing from the news, they were terrified, and she was terrified. She was waiting in the waiting room to see me. A patient sneezed and she burst out crying. By the time she got into the consultation room with me, she was more than happy to tell me she did not want chemotherapy. She wanted to get out of the hospital as soon as possible. Thank you very much. And so you can imagine for that lady, I did not give her chemotherapy, and it was fine by her. So I would say really for about 90% of my patients, the conversation went fine and they didn't want treatment. Ironically, there were some patients that wanted to stop their treatment even though it wasn't appropriate. So I had a gentleman who had oral tablets that he'd been taking for his melanoma, and they had kept his melanoma under control for, over 10 years, which is almost unheard of for melanoma. And he wanted to stop taking his tablets, which would have been a disaster. So I had to convince him that we would dispense to him, like I said, 3 to 6 months of tablets. He just had to come and pick them up, and I would call him, and that was how we were able to continue his treatment. But really, it also came down to listening to the patient's side of the story, which I had to do. There were some of my patients who were having priority 4 or 5 chemotherapy, who had weighed up the risks versus the benefits, and they were adamant that they wanted to continue on their chemotherapy. And for those patients who had a good argument and who knew the risks that they were taking, what we did as a department was to make sure that they signed the consent form so that anyone who was continuing on chemotherapy would say that yes, they understood the risk of COVID-19, they understood the risks of coming into hospital, and they were still willing to take that chance either way. And so for those patients, we were able to listen to their side of the story and continue with treatment. And that really alleviated a lot of the problems that we may have had otherwise. We didn't really have too many angry reactions. So how did we actually go about administering the chemotherapy itself? All of our patients were supplied with masks whenever they came into hospital. We encouraged them to bring their own, but if they didn't, then we would supply them with masks. We did not allow patients to come in with any relatives or companions when they were actually coming in for treatment. The relatives just dropped them at the hospital and then had to leave. When they were actually getting the chemotherapy, they were socially distanced as much as possible. And for any patients who had previously tested positive for COVID-19, then they were treated in a side room until they were at least 2 weeks after their COVID-19 infections or symptoms had resolved. For patients who had active COVID-19, then obviously we did not give them any chemotherapy at that time. We obviously were very, very strict about cleaning all our surfaces and equipments and chairs between patients' treatments. And we took our hand washing very seriously, both the staff and the patients. In terms of testing for COVID-19, we did not routinely test patients coming in for chemotherapy for COVID-19, nor did we routinely test staff members. Staff members were really only tested if they were symptomatic and needed to take time off work, or if a member of their family was symptomatic for COVID-19. Chemotherapy patients were not routinely tested. Cancer patients were only routinely tested if they were coming in for actual procedures, so things like surgery or radioiodine treatments. Only if they were coming electively for a procedure were they tested, but not for chemotherapy. So in terms of what the staff were actually wearing, this is me at the end of February, beginning of March in full PPE gear. This was before the lockdown and before, ironically, before the actual full implementation of COVID-19 guidelines came into our department. The patient I was seeing did not have COVID-19. He didn't really have that many symptoms of COVID-19. He had a cough or something. We all knew he had the flu, but because this was just at the beginning of the COVID-19 pandemic, everyone was terrified. So we had full PPE gear for everybody and he was in a side room. The problem we had was that as soon as COVID-19 became serious and lockdown started, we realized that we would not be able to afford to dress all of our doctors and nurses this way to see COVID-19 patients. So we rapidly de-escalated from full PPE to this scenario. So you would only get full PPE with the visors and gowns and everything, gloves and FFP3 face masks. That was only used if you were conducting an aerosol generating procedure. So if you were doing suction, if you were using invasive ventilation like BiPAP or CPAP, if you were doing a bronchoscopy, open suctioning, anything that would induce sputum, it's only under those circumstances that you would receive the full PPE. And you can imagine in an oncology department, that is rarely the case. We don't tend to do a lot of intubation, extubation, and all these kind of aerosol generating procedures in our oncology department. So the vast majority of time, in fact, all of the time since then, our staff were only wearing the masks and the surgical masks, normal surgical masks, and plastic aprons with gloves when we were seeing patients. So this included when chemotherapy was being administered, they would only wear this. When we were seeing patients acutely on the admissions ward, during clinic appointments, and even when we were reviewing patients on the COVID-19 ward. So these are patients who were confirmed as having COVID-19, who had symptoms of COVID-19. Even when we were seeing those patients and being stationed on that ward with positive COVID-19 patients, we were still only wearing surgical masks, gloves, and an apron. So in terms of how we actually dealt with our acute admissions, we had two wards. We had, well, three wards really. We had two clean wards, so that meant wards where no COVID-19 patients were allowed, and we had a COVID-19 ward exclusively for patients who were being tested or known to have COVID-19. We tried to minimize staff movement between these wards. So basically, if you were on the clean ward, you stayed on the clean ward. If you were on the COVID-19 ward, as a staff member, you stayed on the COVID-19 ward, you went home, you would not go from the COVID-19 ward into the clean ward or vice versa. So the doctors or sometimes the nurses on call would triage the patients. So they would take a phone call from the patient and find out what symptoms they had. If they had no COVID-19 symptoms, they would be directed straight to the clean ward. If they had any symptoms suspicious of COVID-19, or if they were confirmed as being COVID-19 positive, they would go onto the COVID-19 ward. This is how we started in the initial weeks, but after a little while, it became evident that some patients who initially did not have COVID-19 symptoms would later develop COVID-19 or be found to be COVID-19 positive. So for this reason, we then changed our system that everyone had to go triage via the COVID-19 ward, and they would only be allowed onto the clean ward once they had been confirmed as being negative for COVID-19. So in terms of the patient outcomes, to be honest, it is really quite early to say how this whole change in chemotherapy administration and how COVID-19 has affected our cancer patients. But we know that there have been some predictive models that have shown that, at least in the UK, for some of the major cancers, breast cancer, colorectal cancer, lung cancer, and esophageal cancer, they have predicted a significant increase in mortality in all of these cancers over the next 5 years. But interestingly, this increase in mortality is thought to be due to delays in diagnosis and also the impact that will have on radical treatment. It is not thought that this increase in 5-year mortality will be due to the changes in chemotherapy in general. It's more the delays in diagnosis and impact on radical treatment. As I said before, when we first started on the COVID-19 journey, we were worried that giving patients chemotherapy whilst they were having, whilst there was a COVID-19 pandemic would put them at a higher risk, and they would have a higher mortality if they did contract COVID-19. But interestingly, we've had a study done in the UK that shows that this is not the case. Now, in fairness, studies done in other parts of the world, I think in the US, for example, have contradicted this. So the data is not 100% definite, but certainly this study done in the UK has shown that we might not be putting patients at an increased risk. So they had 800 patients who are known to have cancer, who had been diagnosed with COVID-19, and they divided them into those patients who had had chemotherapy within the last 4 weeks, so recent chemotherapy, versus patients who have not had any chemotherapy over the last 4 weeks. They basically found that 281 patients who had cancer and were COVID positive had had chemotherapy within the last 4 weeks, whereas 519 patients who were COVID positive cancer patients had not had any chemotherapy recently. And of those patients, of the 800 patients in total, 226 patients died. But overall, 29% of those patients who had had chemotherapy within the last 4 weeks died. And similarly, in the group of patients who had had no recent chemotherapy, the death rate was still 29%. So really, there was no significant difference in the death rate between patients who had had chemotherapy within the last 4 weeks versus patients who had not had any recent chemotherapy. And so the study concluded that there is, as far as we know, no significant association between increased mortality and recent chemotherapy. The things that did have a significant impact on patient mortality were patients' ages. So like I said, if you have a patient who's above the age of 60, and in this study they found that really the median age for the patients who died of COVID-19 was 73. If you were male, you had a higher chance of dying. And also if you had comorbidities like cardiovascular disease, hypertension, that would put you at more at risk of dying from COVID-19. And then in terms of another aspect of our patient outcomes, this is patient shielding. In the UK, any patients who were diagnosed with cancer and having active treatment were advised to shield. And this was like a higher level of lockdown in the UK. So these patients were told that they had to strictly avoid contact with symptomatic people, which is obvious for everyone. They were not allowed to leave their homes. They were not allowed to attend any gatherings of friends or families. Even while they were living in the same household, they were told that they should not spend significant time in a shared space. So they shouldn't be in the kitchen with their families. They shouldn't be in the sitting room. They shouldn't even sleep in the same bed as their partner or their loved one as their partner or their loved one who they'd been married to. And they couldn't even eat. They were advised not to even eat at the same table. They were advised that they should take their meals into a separate room to eat whenever possible. And thankfully, the shielding guidelines have eased significantly as we've been coming out of lockdown. But in the height of lockdown, this was a big problem. And we can't really estimate the impact that this has had on a lot of our patients and their families. I know of at least one patient whereby he had a cancer and he was living with his wife. He was quite elderly. He was advised to shield, and him and his wife stuck to the shielding guidelines very, very strictly. They didn't see each other hardly at all, even though they were living in the same house. Unfortunately, he became unwell with the symptoms of his cancer. He came into hospital. He actually contracted COVID-19 while he was in hospital. And then whilst he was in hospital, his family were not allowed to see him, and he ended up dying. And his wife has since then really struggled to deal with the fact that the last few months she had with her husband, she ended up not seeing him, even though they were in the same house, due to these shielding guidelines. So it is really important that when we do come out of COVID-19, and as we're analyzing the outcomes from COVID-19, we look into the impacts this epidemic has had psychologically on patients, not just with chemotherapy and treatment, but also with the lockdown and with the shielding that they've had to go through as well. So where are we now in the UK? Really, over the last 6 weeks, things have changed dramatically. The UK is easing out of the COVID-19 lockdown successfully. Like I say, Leicester probably more slowly than other parts of the country. We have no administration and no restrictions right now on the administration of chemotherapy. So we're now offering chemotherapy to all of our cancer patients as usual, regardless of their age or comorbidities. We've basically gone back to how we had been pre-COVID. I have to say that the strict restrictions we did on chemotherapy lasted only a few weeks. It was about 6 weeks ago that we started easing out of those restrictions, and now we're giving chemotherapy at full blast. And it's not really had a negative impact in terms of admissions with COVID-19 thus far. What we found was that in the height of the COVID epidemic, around April time, our hospital admissions decreased significantly by about a third. So whereby on average, we would have about 600 or 600 to 700 patients admitted per month. Our admissions dropped down to about 400 per month, and that was because patients were scared to come into hospital. But ironically, even though our admissions rate significantly decreased, our mortality rates increased by about 2 to 3-fold. We haven't finished completing all the data, so we don't know how much of that is significantly due to COVID-19 or due to patients presenting to hospital later than usual because they were worried about coming into hospital. And so that data is pretty much to be confirmed. The precautionary guidelines we have for administering chemotherapy still remain in place, so we're still doing the social distancing and making everyone wear masks. Thankfully, like I said, the patient shielding recommendations have reduced. The full impact on our cancer patients, both physically and psychologically, are to be determined. There is no significant evidence of recent chemotherapy causing an increased mortality from COVID-19. And in terms of the increase in patient mortality for cancer patients, this is thought that it will be most likely due to delayed diagnosis and the reduced radical treatment that we offered patients during the COVID-19 pandemic. So that's my presentation on chemotherapy in cancer patients. We're not going to take the questions now, we'll take them all at the end. So I'm just going to move now onto the palliative care aspect of this talk. I'm going to be focusing more on palliative care on COVID-19 patients in general, not just cancer patients, but how we manage, how we can offer palliative care to all of our patients who are dealing with COVID-19. I will start off by talking about why palliative care is important in the first place, and then move on to the management of COVID-19 symptoms, and then talk about end-of-life care. So why is palliative care important? So palliative care is actually one of my passions, I have to say. Normally when I give this talk, I give it in the setting of cancer because, as we all know, a lot of our cancer patients will require palliative care. But actually now we're in a situation where it's not just cancer patients that are seeing a high mortality rate. It is all of our patients who, well, not all of our patients, but a significant number of patients who present to hospitals with severe symptoms of COVID-19 might be faced with a terminal situation. And so when we see these patients who come to hospital, they're very short of breath, we're worried about the fact that we may or may not have ventilators, we may or may not have the infrastructure to deal with them. We equate this COVID-19 pandemic with death. And when we equate something with death, it makes us feel like failures as doctors because we feel like we're helpless to help these patients. And particularly, like I say, when we face the frustrations of we as doctors, as I don't know what it's like in your individual hospitals, but you might be struggling to get hold of PPE in the first place. Finding a ventilator or the staff to operate the ventilators might be a problem. It can make us feel helpless as doctors. But what we have to remember is that actually the majority of COVID-19 patients will survive even without needing medical intervention. The majority of patients who come into hospital can survive COVID-19 without the need for ventilators. But what we do need to be able to do is support these patients with all the symptoms that they might be having and all the concerns that they might have, both as patients and their families. And this is where palliative care comes in. So what is palliative care? Palliative care is an approach that helps improve the quality of life of not just the patients, but also their families when they're facing a life-threatening illness, be it cancer or COVID-19 or cardiovascular disease or respiratory problems. We have to try and prevent and relieve the suffering these patients might face, and that is done by identifying and assessing any symptoms that they might have early on, and so we can treat these symptoms most effectively. Palliative care is often associated with death, and it doesn't really aim to hasten death or postpone death, but it aims to just address death as a normal process, a process of life, really, and that we have to face as doctors. It integrates psychological as well as spiritual aspects of patient care. And it also offers a support system to help the patients live as actively as possible until death. So we want to ensure that they have the best quality of life they can possibly have right until the time of their passing away, or until we are able to discharge them from hospital successfully. It also is supposed to positively influence the course of their illness. Now, what we have found in cancer care is that if we are able to offer patients appropriate palliative care as early as possible in their cancer journey, then that palliative care alone, just by helping with symptom control, has been shown to improve patients' prognosis and reduce patients' admission to hospital just as much as some of the chemotherapy drugs that we give. So really, good palliative care can be just as effective as chemotherapy or any of the medications that we give to our patients that come into hospital. And also, if we give good palliative care in conjunction with other therapies that are supposed to prolong life, then this can help manage some of the complications and side effects and toxicities of the treatments that we give our patients. In order to effectively give our patients good palliative care, we have to educate both ourselves as healthcare professionals and the patients and their families on the truth of palliative care and dispel a lot of the myths that we have. So one of the main myths is that palliative care can hasten death. And that is just because a lot of the patients, by the time they get referred to palliative care, or by the time people start thinking of palliative care, they're already at the end stage of their illness. So sometimes there's a misconception that palliative care has caused this. But the truth is that the patient is already at the end stage of their illness, and palliative care is supposed to offer the comfort that they need and optimize their quality of life as they reach end of life. The second misconception is that palliative care is only for patients who are dying from cancer. And as this talk will show, it is not just for cancer patients, and it's certainly not just for patients who are dying. It is for patients who are in need of symptom control, whether they have COVID-19 or cancer or any other illness. People often worry about pain when it comes to dying. Pain does not always have to be part of dying, and certainly patients who struggle with COVID-19 may not at any point struggle with pain, but we also have to be aware and be able to manage the symptom of pain if we come across it by giving patients appropriate medication. Which leads me to my next point, and I was very interested to hear Dr. Adeyeye at the beginning speaking about the availability of opiates and morphine in Nigeria, because opiates are a key part of palliative care, certainly in the United Kingdom. There are a lot of misconceptions. There are misconceptions that morphine can lead to death or to addiction. And for this reason, a lot of healthcare professionals are very reluctant to prescribe morphine and opiates, but we do a disservice to our patients if we do not offer them this treatment when it is needed. The key, again, is appropriate education on how best to use opiates, how best to dose opiates, and inform not just healthcare professionals, but also the patients and their family members of what to expect and how to manage it. By definition, if you have a patient in pain and you give someone in pain an opiate, they cannot be addicted because they're using the opiate for a reason. But we have to have an appropriate exit strategy as well to make sure that once the pain is under control, we know how to wean the patient off the opiate to ensure that they don't get addicted. And to make sure that as we're introducing the opiate, we do it at a gradual level so that we don't face things like opiate overdoses that can then lead to death. So it's about how we manage our education and appropriate administering of the drug. The second key part in palliative care is communication. Communication is essential to make sure that we give patients the best care that we possibly can. And to be honest, it's not just in palliative care, it is in all medical care that we need to ensure that we give patients appropriate treatment by communicating with them. And we know the benefits of effective communication. If we develop a good rapport with our patients, then it means that they will open up to us better and explain to us their needs and their expectations more effectively. And therefore, we as healthcare professionals can address those needs more effectively. That will increase patients' compliance, and that will improve patient outcomes. And it can also help us deal with the patient's expectations and make sure that we address this appropriately and are more honest with our patients about what to expect. And from that way, we're able to get better patient satisfaction, but also better satisfactions as healthcare providers. Because for me in particular, there's nothing more frustrating than having a patient that I've prescribed 100 tablets to and they don't take them, or that don't turn up for their clinic appointments. So if we can have better communication, then we can make sure that we give the patients the best care possible. So how do we manage COVID-19 symptoms specifically? We all know the symptoms of COVID-19 by now. The main thing that patients will present with will be a cough, shortness of breath, air hunger because they really are struggling with breathlessness, high fever, distress, delirium and agitation, and there's a significant risk that our patients can deteriorate and die very, very quickly. So how do we deal with that? So in terms of the treatment of patients suffering from COVID-19, there are a lot of different active treatment measures that we can take. So we can give them fluids and oxygen to help support them. We can give them antibiotics and antivirals, not so much because we know that these antibiotics or antivirals can cure COVID-19, but because we are helping to reduce the chance of the patients contracting opportunistic infections that would also have a negative impact on their outcome. And also for patients who then continue to struggle with breathlessness and go into organ failure, then we can give them ventilator support or renal replacement therapy, and basically, if necessary, give them intensive care support. But alongside that, we need to make sure that we give them high quality, compassionate symptom control. And if the need arises, we need to give them appropriate end-of-life care as well. So in terms of the breathlessness that is really known to be the main cause of concern with COVID-19, those patients who come into hospital with severe breathlessness have been shown to have a worse prognosis than other patients who present with other significant symptoms of COVID-19. We can start off with non-pharmaceutical measures like positioning. Appropriate positioning supports the muscles in the body that help us with our breathing. So simple things like getting the patient to lean forward, and depending on the fitness of patient, they can either do that standing, sitting, or lying down. This just helps them get their body in the best position to have effective breathing. Then you move on to breathing techniques. So often a patient who is short of breath will get very anxious, very distressed, and they start hyperventilating. So you have to talk them through breathing techniques, get them to take slower breaths, inhale through the nose all the way through their diaphragm into the abdomen, and then exhale slowly through pursed lips. And this will help slow them down and reduce the anxiety they're suffering from. Then you can try relaxation techniques, such as speaking to them, getting them to listen to music, using a cold cloth or flannel on their face, and opening the windows. I know in Nigeria, this is a lot harder because obviously the temperature is significantly hotter than in the UK, but we are advised against using fans because it circulates the air and can increase the risk of passing around COVID-19. So we discourage the use of fans, but either way, you want good circulation of air, good air entry coming into the room, so you can try opening windows for the patients. If the non-pharmaceutical measures on their own are not sufficient, then you have to move into more active forms of treatment, so you can give the patient oxygen where available. And then we go to our old friend opiates. So this is what I'm talking about, the importance of using opioids in patients. Now, we all know that we were trained in medical school or nursing school as healthcare professionals that there is a risk of respiratory arrest or respiratory distress when patients take opioids. And for this reason, a lot of healthcare professionals are reluctant to give opioids to their patients who are breathless. But that's why I've included this paper in this presentation, because this paper actually from the Journal of European Respiratory Medicine shows that the use of opioids in patients who have breathlessness does not increase the risk of respiratory distress. So it is safe to use opioids in patients who are breathless, because what the opioids do is they do decrease the respiratory rate, but that is without causing hypercapnia or hypoxia. So it helps your hyperventilating patient to slow down their respiratory rate and makes their breathing more effective. Again, you have to look into the dosage that you're giving. So you start with a lower dose of the opiate. You can have oral morphine, so Oromorph, that you give at a dose of 2.5 milligrams, and you can increase that to 5 milligrams orally. They can take it as required with an interval of about an hour between each dose to help with the breathlessness. You can also give morphine sulfate modified release, 5 milligrams twice daily to a maximum of 30 milligrams per day. Remember that the opioids will have side effects of nausea, vomiting, and can cause constipation. So remember to give them antiemetics and laxatives as you're giving them the opiates. And also because of the distress caused by shortness of breath, like I said, a lot of the patients will be anxious and going into anxiety because of the shortness of breath. So you can try and calm them down by giving them anxiolytics. So if you give them, again, lorazepam 500 micrograms, start with a low dose because we know that benzodiazepines and opiates can interact. So start off with the opioids first, see if that does the job. But if it does not, then you start off with a low dose of a sedative such as lorazepam or midazolam. And again, increase the dose slowly as required. With the midazolam, you would start at 2.5 milligrams as an injection, and you can go up to 5 milligrams that can be given hourly. If you have access to a syringe driver, then these drugs can be put in syringe drivers as well to help with the patient's anxiety and breathlessness. In terms of the cough, we know of the non-pharmaceutical measures, simple things like honey and lemon in warm water, cough sweets, keeping the patient well hydrated so that their throat does not get dry, and elevating their head when they're sleeping. Obviously, because of COVID-19, we want to make sure that we don't increase the spread of COVID-19. So encourage people to cover their faces when they're coughing or sneezing, then throw away whatever they've used, any tissues they've used, and then wash their hands immediately afterwards. If their coughing persists, then codeine linctus, the codeine liquid, is very, very helpful in controlling coughing, 30 to 60 milligrams up to 4 times a day. And if that doesn't do the job on its own, then we can add in or change to oral morphine, again, starting at a low dose, 2.5 milligrams up to 4 hourly. General distress and anxiety that patients experience with COVID-19. So this is something that they will have because of their diagnosis and because it's just one of the known effects of COVID-19. Having someone else with them is always helpful. It can be difficult when you're trying to maintain social distancing and reduce the number of visitors that you have in the hospital setting, but we do know that having another member of their family there helps. Spiritual support is essential, and that is something that I'm sure is done a lot better in Nigeria than in the UK, but offering them the support they need at this very distressing time. And again, we go back to the sedatives. So lorazepam and midazolam giving orally or sublingually in the case of lorazepam, or for midazolam, you can give it as hourly to 2 hourly injections or as a syringe driver where available. This can help reduce the distress and anxiety. And thirdly, you can use levomethomazine. We often use that as an antiemetic, anti-sickness drug, but it also can be given sublingually up to hourly to help with reducing anxiety and distress. Fever and delirium. So fever, simple, paracetamol. So you can give paracetamol orally or intravenously, 500 milligrams to 1 gram 4 times a day. That can help bring down patients' fever. But delirium is a little bit more complicated. So a patient gets delirious, they're anxious, they're agitated, they're all over the place. The temptation is to try and restrain the patient and hold them down, but this actually is not appropriate. We try and avoid restraining the patients as much as possible because that just increases their agitation and it adds to the delirium and it makes the whole situation worse. Wherever possible, you want to encourage them to actually mobilize. So getting the patient to walk around, maybe even walk around their bed, but have someone with them the whole time. That can help reduce the agitation that they get with delirium. And also, again, you can use some form of sedation. Now, you have to be really careful when you're sedating patients who are delirious because some of the sedatives, like lorazepam, can actually increase the delirium or cause the delirium in the first place. So in this situation, we swap to using haloperidol instead. Haloperidol, a dose of 500 micrograms up to 2 hourly, or olanzapine can be added to the haloperidol if the haloperidol on its own doesn't work. Only if you use these 2 drugs and they're not being effective, only at that time can you consider adding other sedatives. But you would have to continue monitoring the patient to make sure that the drugs you're giving are not making the situation worse instead of better. And finally, moving on to end-of-life care. So I love this quote about end-of-life care because it really is important that we offer our patients the best care possible at the end of their life, as opposed to the temptation, which is a lot of the time when we as healthcare professionals see patients that are dying, they can often get sidelined or discharged or left alone. And a lot of the time our patients do say that they feel like everyone gave up on them. But actually, this quote says, "It is a privilege to care for the sick. It is an honor to be present when human beings are brought into this life and when they leave. So it is also an honor to ensure that our patients get the best quality of care at the end of their life, just as much as they did at the beginning and during their lives." So in terms of end-of-life care, the main thing is anticipating it. It is about knowing that this patient is reaching their end of their life and trying to anticipate what problems are they going to have, what symptoms are they going to have, what support are they going to need, and to preempt that and deal with it accordingly. We need to review the medication that they're taking and make sure that we keep only the essentials. If you have a patient that is weak and struggling to take medication, there is no need for someone who has a prognosis of 2 to 3 months, let alone 2 to 3 weeks. There's no need for that patient to be continued on simvastatin or anti-cholesterol drugs. If you have a patient that is within days to weeks of dying, there is no need to continue giving them IV fluids. You can imagine they're dying. The fluids are not going to significantly improve their quality of life. All it means is that you're inflicting pain on a patient when you keep coming in every day to stick a cannula into their arm and stab them with a needle and their veins are collapsing. It actually makes the end of their life very distressing. So you do not need to continue non-essential medication. And fluids are one of the things that we as doctors and family members as well, there's a temptation to continue them on fluids so it feels like we're doing something, but actually we're not doing anything. We're just inflicting unnecessary pain on them. In the Nigerian setting, inflicting unnecessary costs on their families when it's not actually helping improve their quality of life at a very distressing time. So we want to avoid unnecessary interventions as well. So if blood tests are not going to help, don't keep doing blood tests. Even taking their temperature and blood pressure, if that's not going to change your management, then stop doing those interventions as well. Just focus on symptom control and supporting that patient. Effective communication is essential. So when I spoke to other doctors, particularly in the Nigerian setting, about stopping all these interventions, stopping fluids, stopping observations, the next thing they said is, but the families will be upset, the patients will be upset. They'll say that we're not doing anything to help them. But this is where the communication comes in. A lot of the time, actually, the patients themselves, I found, can tell when they're dying. Their families can probably tell when they're dying. It's just that nobody wants to address the elephant in the room. Nobody wants to talk about it and explain what's going on. And it is actually our responsibility as healthcare professionals to then open the conversation so that we can deal with the situation effectively. And what I found is if we are able to say to the patient and their family, look at what's going on. What do you see? What do you think is happening here? Half the time, they will tell me that they already know that they're dying. And then we can say, yes, this is what I think as well. What is the best way we can manage the situation we're in now? Let us stop the drips that are stabbing you all the time. Let us reduce the cost for you and your family in terms of buying medication and paying for blood tests and all that, all those things that are not necessary. And let us see how we as doctors and nurses can support you and make sure you have the death that you would like, or that you can reach the end of your life in the most comfort. So it's also about providing the support for the family and the carers of the patient, as well as for the patient themselves. Again, like I said, I think in Nigeria, you will do this better than in the UK, addressing the patient's religious needs and saying, you know, what do they want a priest to come and pray for them at this time, or an imam? And then we move on to the problem of pain. Like I said, a lot of people, when they talk about death, they're worried that they're going to be in pain. It does not always have to be the case that the patient will be in pain, but if they are in pain, we need to know how to manage it. So we use the WHO analgesic ladder, which I'm sure you're all familiar with. Step one is if they have mild pain, you start off with just paracetamol or non-steroidal. Yes, they can take paracetamol and the non-steroidal together. If just taking one is not effective, you can combine the two. If the two together do not do the job, then you can move on to a mild opiate, so something like codeine or tramadol or low-dose morphine. You you can add any of those low dose opiates to paracetamol. You can take paracetamol in combination with those. And in fact, it's encouraged that we do that because they have a synergistic effect in controlling pain. But do not add codeine to tramadol. There's no benefit in adding codeine to tramadol. Just use one or the other. If on its own codeine is not working and then you add paracetamol and still that's not working, that means that you have to move on to a stronger opioid. So this is when you start using morphine or oxycodone. And you can also use fentanyl or buprenorphine patches. But what we say is that make sure you understand the dose of opiate the patient needs. It's better to use fentanyl patches and buprenorphine patches when the pain control is steady. So when you know the dose of morphine that the patient needs regularly, then you convert it to a fentanyl patch or buprenorphine patch. Remember that as we all know, morphine causes a lot of side effects. One of the main side effects is constipation. So we have to preempt that by giving the patients laxatives early on so that as they take the morphine, they don't then develop severe constipation as a side effect. The other side effects that we know that the opiates cause are things like nausea and drowsiness. So anticipate the nausea, give them antiemetics that they can take. Metoclopramide is very helpful, haloperidol as well, to preempt the nausea and vomiting so that patients don't just stop the opiates the moment that they get nauseated. They can get drowsy from the opiates, so just warn them in advance that this is a side effect that you are likely to experience. It should clear within 7 days. If it persists, let us know, and then we can reduce the dose of the opiate. Myoclonus, I have not seen very often, but it is possible. So make sure that your patients are not in renal impairment before you start them on an opiate. If they are in renal impairment, you can still give them an opiate, but reduce the dose and consider giving them something like oxycodone instead of modified release morphine sulfate. And also, if the patient is in the terminal phase of the illness, then you can consider giving them midazolam as well. In terms of hallucinations, that means that the patient has a poor tolerance of the opiate, so reduce the dose of the morphine or change it to a different opiate altogether. So like I said, if they can't tolerate morphine sulfate, then try oxycodone or oxynorm instead. Respiratory distress, we have addressed it before. Like I said, you should not cause respiratory distress in a patient if you are dosing their morphine appropriately. If you start at a low dose and only increase the dose gradually, the patient should not hit respiratory distress. But if they do, because maybe you've mixed the opiate with a benzodiazepine, or if they've gone into renal failure, or if you've increased the dose of the opiate too fast, then you can reverse the respiratory depression by giving them naloxone instead. Be aware that when you give them naloxone, it is short acting. So if you've given someone a dose of naloxone and they come out of the respiratory distress, you need to continue monitoring them because they are likely to need another dose of naloxone later on when the initial effects wear off. And also be aware that the pain might come back in a rebound. So they might get a lot of pain coming on as soon as the naloxone has fully gotten rid of the opiate. So you're going to have to readjust your pain medication again if you've had to give naloxone. In terms of general end-of-life care and other anticipatory medication that we need to think about, we've spoken about pain already, and in the context of COVID-19, I've already spoken to you about dealing with the restlessness and agitation a patient might face and shortness of breath. The other thing to be aware of is they might, at the end of life, struggle with nausea and vomiting, not necessarily because of COVID-19, but just because of other problems that they might have with end-of-life care. So, for example, a cancer patient would often have problems with nausea and vomiting if they have a colorectal cancer, for example. So you can treat that with haloperidol, cyclizine, metoclopramide, and levomepromazine. Be aware that the patient might be getting more weak, and so they might struggle to take oral medication, in which case you would need to change to subcutaneous medication or a syringe driver. And then in terms of secretory, so towards the end of life, I'm sure those of you who've dealt with patients who are dying have often seen that they get what we call the death rattle, which is when they have a lot of mucosal secretions. There's a lot of fluid in the throat area that can also cause them distress. This can be dealt with by giving them hyoscine butyl bromide or glycopyrronium. Again, they're very effective in drying up the secretion so that the patient doesn't have to deal with that distressing symptom. So those are the anticipatory medications that you can give to any dying patient. And so when we reach this scenario, whether it's due to COVID-19 or any other situation where it's looking hopeless, death looks imminent, and there's a risk that we might feel like failures. I am convinced that if we are able to give our patients a good death, then instead of feeling like failures and like it's a hopeless situation, actually it makes us hopeful, because we know that despite the fact that the patient has passed away, death is part of life, but we've still been able to give them the best care possible right until that very end stage of their illness. And so, in summary, not all patients diagnosed with COVID-19 will die, thank God. We know that, but we still need to support them through their illness. So clear doctor and patient communication is vital in order to make sure that we're giving our patients the best care possible. And that is given by making sure that we have early supportive care and good symptom controls that can improve our patients' outcomes. Good end-of-life care is our duty of care. It is not that our duty of care stops when it reaches end of life. It is actually just another level in our patient care for all of the patients we come across, particularly those with COVID-19. Okay, that is me done. I'm now ready to take any potential questions.
Wow. Thank you so much, Shinye, for your presentation. It was quite amazing. And we put you through a lot, trying to run through all these topics in the period of time you had. We really appreciate this and would not take you for granted. First quick question I think everybody wants to ask, and I'm going to ask on their behalf, is that I hope we're going to get access to your slides for us to share.
Yes, sure. I'll be happy to give you access to the slides, no problem.
Okay, excellent, fine. And second point is that this presentation is being recorded, and we usually try to upload them on YouTube after the usual editing at the Live Found TV, but we'll share the link to everybody on the usual platforms. Now, there's somebody who raised his hand, so our hand during the presentation, and would like to have a question. But before then, I have a number of questions in the chat room, and people are sending their thanks. We appreciate that.
Okay,
so many of the questions relate to whether you've been able to manage any patients who was on chemotherapy and was tested positive for COVID-19. Whether you have any experience in managing patients who were COVID positive and had to have chemotherapy during cancer care. And that's okay. You want to answer that?
Okay, yes, sure, of course. Yes and no. So I haven't had, like I said in the presentation, when we have patients who are confirmed with COVID-19, at that point, we would stop their chemotherapy. So if we know they have COVID-19, we would not then persist with giving them chemotherapy. But having said that, if we had a patient who, for example, had chemotherapy last week or yesterday, and then they come into hospital with COVID-19, yes, I've had to deal with those patients. And it's actually very interesting. As that research journal from Birmingham showed, the outcomes are very variable. I've had elderly patients in their 70s or 80s who've had chemotherapy within the last week who had COVID-19, and they did fine. As you know, there have been a lot of clinical trials recruiting, and Leicester has been recruiting to clinical trials for the treatment of COVID-19. We were trying to recruit patients onto that trial. We would have patients who we would offer them treatment on the trial for their COVID-19, and they were actually saying to us, I've got this COVID-19, but I feel fine. I just want to go home. Thank you very much. And they would just, some of them even self-discharged from the hospital because they felt fine despite the diagnosis of COVID-19. But on the other hand, we had some patients, for example, some young, fit patients who were being treated adjuvantly. And out of the blue, they got COVID-19 and they deteriorated very rapidly. We were able to get them onto ITU, but some of them did not survive. So, you know, really it's variable. There's a broad spectrum of outcomes and there's no way of predicting who will do what in this era. So.
Yeah, nice. So that's obviously a potential source of research. Now, there's a quick question on the palliative care before I go back to chemotherapy, that it's quite routine in Nigeria to see patients who are obviously dying, who are anemic, they have symptomatic anemia. And there's this question about whether we should transfuse them or not. What's your take about blood transfusion? There's a question on that.
Okay, so it really depends on what stage of dying we're talking about. I do give blood transfusions to a lot of my patients who are at the end of life stage. But it depends. If they're going to die, for example, if it looks from what you can tell and from your experience that it's going to be within the next week or 2 weeks, then I don't think there's any benefit in giving them a blood transfusion at that stage. But if you have someone who's probably got 4 weeks, 2 months to live, and they're symptomatic, they're breathless, they're uncomfortable because of the anemia, then yes, it is worth giving them that blood transfusion, because you are still, again, optimizing their quality of life for those last couple of months by reducing the symptom of breathlessness. So yes, I would definitely give them a blood transfusion in that situation.
Yes. So there's another question on the end of life care and palliative care. I'll try to read this question verbatim. So it says, do you consider palliative chemotherapy as part of end of life care? If so, do you routinely communicate this with the patients? And do you sign a DNR, that is do not resuscitate, particularly in this area of COVID-19?
Okay, very good question. So first of all, this is one of the things I try to teach my colleagues and medical students. Palliative chemotherapy means different things for different cancers in different patients. So for example, when I'm giving a patient with pancreatic cancer palliative chemotherapy, that to me means that they have advanced pancreatic cancer that I'm not able to cure. So the aim of my palliative chemotherapy is to optimize symptom control and reduce the spread of their cancer. And in a pancreatic cancer patient, that means that even with the best chemotherapy I have, their prognosis is still at best a year. Having said that, if you have a breast cancer patient who has metastatic disease with bone metastases and you're giving them palliative chemotherapy, that breast cancer patient, even though the aim of your chemotherapy is just symptom control and to reduce the spread of their breast cancer, they can still live for 2, 5, God knows how many years. So there's a big difference between palliative chemotherapy in one cancer like hepatobiliary cancers versus palliative chemotherapy with someone who has breast cancer or even melanoma. So for that reason, I would say no. I don't always, in fact, I generally don't say to my patients that palliative chemotherapy is end of life care. A lot of my patients will come in and say, I've been told I'm terminal. And I always say to them, I don't like the word terminal because it makes people think they're going to die in 2 weeks. If I'm offering you palliative chemotherapy, that means that by definition, I believe your prognosis is going to be at least six months to 12 months, because the palliative chemotherapy in itself, the duration of the treatment is at least 6 months. So my patient has to be fit enough to survive a good 6 to 12 months before I even offer them palliative chemotherapy. In terms of the do not resuscitate form, it is still a very good question, because I think we probably don't address this question as well as we should do, even in the UK as well. Yes, we should sign do not resuscitate forms. And that is because if I'm giving a patient with one of my cancers palliative chemotherapy, if they become so unwell that they need resuscitation, the chances are they're very unlikely to survive. And if they do survive that resuscitation attempt, the intensive care doctors are not likely to prioritize that patient to give them an ITU bed over someone who is fitter or younger or has a better prognosis. So if you have a patient with a prognosis of 6 to 12 months and you're giving them palliative chemotherapy, then it is worth discussing the do not resuscitate form with them sooner rather than later. I completely agree with that. But if you have a patient, for example, like I said, with melanoma or breast cancer, who is having palliative chemotherapy that can enable them to live for years, then I wouldn't at that point sign a do not resuscitate form, because there are a lot of reversible things that can cause them to go into cardiac arrest, and yet they might still have a good prognosis. I hope that's clear.
Yeah, yes, it. So there's some other questions on the chemotherapy aspect of the presentation. So someone asked if there were any ethical or legal issues concerning administering chemotherapy to patients who are at risk of having COVID-19, and they're quiet and they say, okay, the hospital was one who made me at risk of having COVID-19. Have we considered any ethical or legal ramifications to this?
Yes. So, like I said, in my presentation, right from day one, as we were managing the situation of who to give chemotherapy to, we as our doctors knew that there were going to be ethical and legal ramifications, more legal than anything else. I know for a fact that at least one of my patients who was having chemotherapy came to our hospital with a complication of his chemotherapy, contracted COVID-19 in the hospital, and he has not sued us legally, but he knows that it was coming into our hospital that caused him to get COVID-19. So that is why we made sure that all of our patients signed those consent forms to try and minimize the legal ramifications that we might face in the future from people saying that they got COVID-19 because of our hospital or because of their cancer care and all the rest of it. We cannot say now what the legal ramifications will be in the future, but what we tried to do was to protect ourselves as much as possible by clear documentation and appropriate consenting for all of our patients.
I think that's a good point here. In surgery, we've initiated a COVID-19 risk consent separate from regular consent form. But obviously, it makes sense to extend this to chemotherapy. Funny enough, I don't know of many other centers, but in the place where I practice, we don't routinely sign a consent form even to administer chemotherapy. We assume that since they accept it is implied, so that's already one issue. So I think it makes sense to encourage people to have consent both for the chemotherapy and for the risk of COVID-19 infection.
Exactly. I cannot emphasize that enough. If you want consent forms for your chemotherapy, they've actually on the internet, you can get it very easily.
Yeah,
the CRUK has made consent forms for every single type of chemotherapy. So it's just a question of downloading it from the internet. It's a pre-made consent form. You just print it out and get them to sign it. And then we also, on top of that, had our COVID-19 form. So yes, I would encourage people to do that.
Yeah, a few more questions. I know we put you on the spot for a while. Please,
it's okay. No, I don't mind. I'm happy to answer whatever. Yeah.
All right. So there's a question about, well, it's a question and a comment all rolled in one, that we have a patient who has cancer, requires chemotherapy, and there's no oral form of medication available to manage these patients. And this patient is probably in the red zone of those who are at risk of contracting COVID-19. Do you just tell them that no chemotherapy and then leave them to their fate? I'm trying to quote that verbatim, the last end of the question.
Okay. So again, like I said, if they needed IV chemotherapy and their region, priority level 5 or 6, and for my patients, and what I have to highlight at this point is the place we are in the UK now is different from where you are in Nigeria now. So you guys are probably a couple of months behind where we were. Sure. I would say that based on what I have seen in terms of how patients have responded to chemotherapy and in terms of the number of patients that we've had diagnosed with COVID-19, it is, if that patient might benefit from the chemotherapy, then please, I would say go ahead and give it. Because I have to say that I personally started bending the rules in terms of who I gave chemotherapy to quite early, because we were so terrified by what was going on in Italy. We were so scared by what we saw in Italy and London that we just cut back on chemotherapy treatment. But actually, even when COVID hit us at its height, it never reached the level we were afraid it was going to reach. And so I would say go ahead and give them the chemotherapy, but monitor them very closely. And again, speak to them about the risk of what you are doing. And just make sure that they know if they have a temperature, come into hospital, just educate them as you're giving them the treatment.
I think there's one final question for you, and then there's a comment for me before we take the person who has a comment. So the question the person has, or one of the comments, is related to the study from Birmingham concerning the patient outcomes. So the person's comment is that, do you think the positive findings from those studies may be due to the fact that the patients were strictly selected and you weeded out all those who would give poor outcomes? That it was as if it was just it was not a real life scenario that was encapsulated in that study.
No, I think they did. I don't think they deliberately biased the outcome of the study. If you look at the actual graph, I can't go back and show, but if you look at the graph itself, you'll see that there were some patients who were recruited who had mild symptoms, moderate symptoms, and severe symptoms. It's a very interesting way they've drawn that graph. It makes it difficult to sort of follow it through, but what you'll see, the gray lines sort of link the severe symptoms to the cancer patients. So there wasn't any significant bias in them weeding out patients' severity of symptoms versus their actual outcomes. So no, there wasn't any bias. And like I said, anecdotally, from the patients I have seen, when I'm on call, you spend 5 days on the clean ward, and then we spend the weekend, so that's 2 days, on the COVID-19 ward. So that would be us dealing with cancer patients who have tested positive for COVID-19. And I would say anecdotally, from what I myself have seen, there is no significant negative outcome. I wouldn't say that, oh yes, all the cancer patients that catch COVID-19, I can obviously see that they're all dying. That is not the case. You have a lot of the patients I had a patient who had COVID-19 when he was diagnosed. He was very, very breathless. We did the test the first time, it came out negative. We did the test the second time, it came out positive. He looked like he was going to die within the next 2 weeks because of his COVID-19. But actually, once we discovered it was COVID-19, we got him on the COVID-19 ward, we treated him. He recovered really well. He started chemotherapy. He's halfway through his chemotherapy. He has not recontracted. He has not got any new symptoms, and he's doing brilliantly. So, really, I wouldn't say that that study doesn't appear. It doesn't appear to be biased based on what I myself have seen.
All right, great, excellent. So there was a comment for me at the beginning of the discussion. I mentioned the fact that the WHO recognized that there is no national guideline for palliative care or even for cancer treatment in Nigeria. And somebody raised an issue that there's an NCCN guideline tailored for Sub-Saharan Africa, which is true. It's called the NCCN Enhanced Guidelines. So it's supposed to be tailored towards cancer care guidelines for Sub-Saharan Africa and low resource settings. Unfortunately, those guidelines are not that popular, and I know most people don't follow those guidelines. And WHO's recognition was not a Pan-African guideline, but mainly a national-based guideline or program. So that's why they said that Nigeria does not have its own core national guideline. But we agree that there's a guideline for Sub-Saharan Africa tailored towards NCCN, but it's not that popular among many of the practitioners that I interact with. So that's my comment to that question.
Can I just ask, when you say not popular, is it not popular because people know it's there, but they don't want to use it? Or is it not popular because people don't even know it's there?
Multifactorial. Some people do not know that they exist. And then when some people look at it, people don't always follow guidelines. So it's an issue that I think we need to address. Probably another discussion on a webinar on guidelines for cancer care, because at least they need to create the awareness for it. I think I've taken all the questions and comments that we have in the chat room, but there's a participant. The participant's ID name is Samsung 8, but he's identified him as Dr. Tuko. So let me try to identify him or her, and then I've unmuted Dr. Tuko. So you have a question or in the comments. I think I've unmuted you.
Okay. So thank you, Dr. Chine, for the wonderful, wonderful presentation. I'm glad I caught up with it. So just a few comments and questions. I was glad you were able to elaborate fully on the issue of palliative chemotherapy, because sometimes I'm a clinical oncologist. I practice in northern part of Nigeria. So sometimes when I do recommend palliative chemotherapy, there's always that, should I say, problem, I have with patients, and even sometimes among some of my colleagues, because, they feel if this patient is on palliative care, what's the point of giving palliative chemotherapy or any other form of treatment? So, you really have to keep talking that the issue of palliation or palliative care is actually a spectrum. You may have a patient who has a life expectancy of less than 4 weeks. You have a patient who has a life expectancy of much longer. So you have patients on palliative care for years. You have patients on, so it really varies, and it depends on, of course, the experience of the clinician and so on and so forth. So I'm really very happy you were able to elaborate on that. And not just palliative care, there are also, palliative radiotherapy, palliative surgery, and all of this. So it's really a spectrum, and, you should, of course, with experience and all that, know where to, where to place your patient. So thank you for that. Then I have another comment or a question. I think it's a question. So knowing that cancer and its treatment can cause immunosuppression, would you, from your, or if you have any data, in fact, or from your observation, cancer patients where you practice or in the UK, do you have any data stating that cancer patients are actually more susceptible to getting COVID-19 than the non-cancer patients? Then second, sorry, this is COVID, no negative. So was stage a considered factor? Were they all early stage, or was it, cut across all stages? Or could you just...
Do you mean the graph with the breast cancer, colorectal cancer, esophageal cancer, and is that the graph you mean?
Yes, I think that's the one.
Okay.
Because, generally we know that treatment delays, treatment interruptions invariably would lead to tumor recurrence and all of that. So, you know, I just wanted you to just elaborate just a bit on that.
Okay, no
Thank you
problem.
so much.
No problem. So the first comment that you made about people being reluctant to give palliative care, then yes, I would say we should, you know, if that's the situation you're facing, please do push for it. Obviously, like I said, if the patient's prognosis as they're sitting in front of you, they look like someone who's not going to survive more than 3 months, then do not start palliative care at that point because they might not be fit enough to tolerate it. But if they look fit enough to tolerate it and their prognosis looks like 6 to 12 months, then please, yes, by all means, they should be getting palliative chemotherapy. That's the first point. The second point about whether we have any data, solid data about whether patients with cancer are more likely to contract COVID-19, I have to say it is more of a speculation that I'm aware of because we know about cancer patients having immunosuppression. So whether there have been any specific papers to this, I have not yet seen them, but I believe they're in the process of coming out. There were a lot of prospective papers done. And even that graph that I showed talking about the increase in mortality in breast cancer, lung cancer, esophageal cancer, colorectal cancer, that was prospective data. So it was basically saying that based on how we would normally screen these patients, based on how we would diagnose them early on, and based on how we would treat them radically, it gave 3 different scenarios of how those patients would normally be treated versus what they will be receiving now. So it was more for in a prospective study projecting, sort of saying this is what we predict has been the change because of COVID-19, and this is what we predict the impact would be. It wasn't an actual study looking at X number of patients because it's still too early in the journey of COVID-19 for us to be able to have that kind of data. But I've put the link for the whole study on there. So if you want to go and read it in more detail, it is there. I hope that answers your question.
Yeah. Okay. Thank you, Chinenye. So we just have 2 more questions I want us to take and then we'll call it a day. I know it's
fine. No, it's okay.
fine. So there's a question on whether you invite psychiatrists and psychologists as part of the MDT when you think about giving palliative chemotherapy to patients who have cancers. And then the second question is, what's your protocol for a doctor for cancer patients gets exposed to COVID-19 or becomes COVID positive and has had treatment? How soon do you get for developing COVID-19? So a doctor who is in care of cancer patient gives chemotherapy, for example, gets COVID-19, gets treatment, and then has to get back into the system. What's your protocol for managing that kind of scenario? So that's the 2 last questions we have. So sorry, we put you on the spot today.
No. I'm very happy. I'm happy to answer any questions and keep talking. So in terms of the psychiatric or psychological support for patients, I think that is an excellent question. We do not have psychologists or psychiatrists sitting in on the MDT. It would probably be better if we did, but we don't at this point in time. But what we do have is what we call the psych oncology team. So we have a specific specialty of psych oncologists who we refer our patients to. So if I see a patient and they're obviously struggling with the psychological impact of their diagnosis, then I just say to them, look, would you be willing for us to refer you to the psych oncology team? They say yes or no. I fill out the referral form and I refer them to the psych onc team. So we have an active service specifically dedicated for our cancer patients. We also have, as part of our palliative care support, psych oncology or psychological support for both the patient and their family is part of the standard care from our palliative care team. So when we if I have a patient that's struggling, not just with physical symptoms, but also with the psychological aspect, a lot of the patients don't like the idea of going to a psychologist. You know, there's some stigma to that still. So for some of those patients, it's easier to refer them via their palliative care consultants or specialist nurse who can support them psychologically there as well. So yes, we do have the framework there, but not specifically in MDTs. In terms of the doctor treated who has contracted COVID-19, I find it a good question as well. It's making me smile because in an ideal world, and when I've attended some webinars from Italy, for example, in terms of how they looked after their staff who were dealing with COVID-19, it is very different from what happened in the UK and certainly what happened for us locally. In the UK, what we were told is if you're an oncologist and you get diagnosed with COVID-19, initially, when everybody was terrified, we would have to take 2 weeks off work and then get retested, and then we would have to, we'd have to be symptom-free before we could come back. Sorry, it wasn't 2 weeks, it was 7 days. Every single day, the guidelines were changing, every day, because it became obvious that the workforce could not handle it. The NHS could not handle it if every time a member of staff got ill, you lost that member of staff for 7 days. It was even worse if you were in a household with someone suspected with COVID. So when we first went into lockdown in the UK, we did not actually have testing kits for COVID-19. We were only going on symptoms. It was very, very hard to get tested for COVID-19. We actually had to start a petition as healthcare professionals to say to the government, you need to prioritize testing healthcare professionals because otherwise you're going to lose your workforce. So initially, if a member of your family got a cough or a cold, you had to take at least 14 days off work. And this was before it was confirmed. The person might have just had hay fever or asthma, but just because they had a cough or a cold, because you're in a household with such a person, you took 14 days off work. So in our department, we ended up having a special rota. We changed the way we worked. We had a consultant who was on call all week to see the oncology admissions. And that meant that that consultant was only going to be on the wards. They would not do any outpatient clinics or any chemotherapy clinics or any other work. As well as them being on the wards, we would have a backup consultant number 1 and a backup consultant number 2 for all of our consultants in case any of them ended up getting sick. So that we would always have a backup person to deal with anyone who got ill. As the time went on and it became clear that the government was going to lose its whole healthcare professional team if they did not start testing us, they then changed the policy to be that if you had symptoms of COVID or if you tested positive for COVID, even if you tested positive for COVID, so long as you felt fine, you could come back to work. But if your family member got tested for COVID, whether you tested positive or not, you could not come to work because they didn't know when you were going to contract the symptoms. So to give you an example, I had a colleague whose partner was positive for COVID. By the time he got the test, it took a couple of days and he felt fine. So by the time he tested positive for COVID and was confirmed as having COVID, his symptoms had disappeared. And for that reason, they allowed him to go back to work. But my colleague, who was his partner, who did not have COVID-19 symptoms and tested negative for COVID, because they said it can take 14 days before she gets symptoms, she could not go to work for 14 days. So she ended up sitting at home for 14 days doing nothing, just because her husband got COVID-19. So if we test positive now for COVID-19, so long as we don't have symptoms, the moment we don't have symptoms, we can come back to work, whether we're COVID positive or not. That's what we do locally.
Interesting. Thank you so much, Chinyere. I really appreciate your time and the erudite presentation. We thank everybody for participating. We spent almost an hour and a half doing this. The recordings will be available shortly, and Chinyere has promised to give us her slides, so we'll just jump to that. All right. So this is a good time to say thank you. We appreciate everybody again. On behalf of our regular host, Dr. Misa Ade, she's again working in the background to make things happen. We'll say thank you for attending this, and we hope to see you soon. Please stay safe. Have a nice week ahead. Bye.
Thank you. Bye.